Good morning. My name is Dr. Jeffrey Goldsmith. I'm president of the American Society of Addiction Medicine, which is also called ASAM. Welcome to this morning's press conference. Today we'll formally release ASAM's National Practice Guidelines on medications for the treatment of addiction involving opioid use. Along with the guidelines, we're also releasing a range of associated resources to help bring the recommendations from the guideline into daily practice and to help improve the quality of patient care. Founded in 1954, ASAM is a professional society representing over 3,600 physicians, clinicians, and associated professionals in the field of addiction medicine. And I was thinking a minute ago, I was remembering a story of two monks, and one of them was questioning the other, and the answer was, the family jewels don't come in the front gate, they come from the heart and go out. And that's what we're doing here today. 2 years ago, ASAM released its research on the barriers patients face accessing medications to treat addiction involving opioid use. When we presented these findings, it was evident that there was a critical need for a national guideline to help define best practices for patient care and to help close the treatment gap. We believe it's significant and timely to host this event during National Recovery Month. To support recovery, we must ensure that all people with addiction involving opioid use have access to quality care and treatment. Joining me this morning are ASAM representatives who were involved in the development of the guideline, including Drs. Margaret Jarvis and Kyle Campman. We're also honored to have several federal stakeholders on both sides speaking this morning along with an impacted family member. Thank you for being here today for this exciting event announcing the release of ASAM's guideline and associated resources. And I'll now turn it over to Dr. Margaret Jarvis. We will ask the media to hold questions until after all our speakers have made their comments. Thank you.
Good morning. I'm Margaret Jarvis. I am the chair of ASAM's Quality Improvement Council, or QIC, and we were the council that oversaw the development of the guidelines that are being released today. We were responsible for selecting the folks who would write this, the committee that helped the vendor create this, and for then making sure that there was an external review process that looked at the written product, as well as making sure that all of ASAM's other quality improvement products were incorporated and used. So the standards that we wrote for physicians and so on and so forth. This was necessary, as Dr. Goldsmith said, because this chronic relapsing disease is claiming lives, hope, and causing death all over the place. And we know that it is a significant problem that has, as of yet, not been treated terribly well in our country. We know that we started this knowing we have medications that are effective, cost-effective, but their utilization is low. The coverage for these medications varies a great deal, and the quality of the treatment in using these medications varies all over the map. So there are many guidelines available at this moment which address medications to be used for addiction involving opiate use. Ours is the first that addresses the 3 different medications that are available for treatment of the disease, as well as the medication that is used to treat overdoses. So it also addresses special populations, and there are a number of associated resources that we will be releasing today, as well as the guideline. And we will make a very concerted effort to keep this particular guideline up to date with yearly reviews for the foreseeable future. We selected the Treatment Research Institute to help write this guideline, and I would like to turn the podium over now to Dr. Kyle Campman, who oversaw that endeavor on the part of TRI.
Speaking from my chair, that'll probably be easier. I don't have to crawl over people. Hey, good morning. I'm Kyle Campman. I'm a professor of psychiatry at the Perelman School of Medicine at the University of Pennsylvania. This guideline was developed using the RAND UCLA appropriateness methodology, RAND-RAM for short. And the RAND-RAM is a method of developing guidelines combining both scientific evidence as well as clinical knowledge to develop recommendations for clinical practice. And we use this process to develop the guideline because the accumulation of scientific evidence in the form of clinical trials sort of lags behind clinical practice for the treatment of opioid use disorder. So using the RAND-RAM method allowed us to develop a set of valid recommendations using this recognized methodology. Now, the guideline includes a whole chapter on the role of psychosocial treatment use with medications. ASAM received funding from NIDA to help with the literature review, and in addition to putting it in the guideline, this has been submitted for a journal article on its own. TRI reviewed all the guidelines that were available for the use of medications for the treatment of opiate use disorder that were available from the year 2000 on. There were 49 of them. 34 eventually made it into the analysis, and most of these were guidelines looking at individual medications. Once the background review of the literature was done, then TRI worked with the guideline committee to develop a series of recommendations. We call them hypothetical statements. These hypothetical statements were then rated for both appropriateness and necessity for inclusion in the guideline. And this is an iterative process. It started with an online rating, followed by a face-to-face meeting and numerous conference calls over many months, in addition to multiple literature searches in addition to that. As we went through the RAND-RAM process, there were recommendations that the committee felt very strongly about that didn't have a lot of coverage in the scientific literature. These were included in the guideline, but were described as consensus recommendations. An example of this would be the use of buprenorphine started at home as opposed to an office-based setting. The committee felt that this was appropriate, but there was really very little in the literature about that, so it got included as a consensus recommendation. The RAND-RAM process also develops research questions, and these research questions were included in the guideline, and it's our hope that NIDA and others will use these research questions as a guide for future research priorities. And that sounds like a real good segue into introducing our next speaker, which is Dr. Nora Volkow, the director of the National Institute on Drug Abuse.
Good morning, I'm Nora Volkow. I direct the National Institute on Drug Abuse, and it's a pleasure for me to be here to discuss the ASAM National Practice Guidelines for the use of assisted medication on opioid abuse disorders. I want to congratulate ASAM for taking this on. It's an extremely urgent and timely issue, as we have all recognized the significant increases that we have seen in prescription opioid abuse in our country that have led to increases in heroin abuse that we had not seen for years. This has translated into a very significant number of overdoses from prescription opioids and from heroin abuse, which have quadrupled over a 15-year period. And this has clearly identified it as an urgent issue. Secretary Sylvia Burwell has taken this very, very actively, and you'll hear details, but there is an HHS plan to actually address it. And among the 3 recommendations are better prescription for the management of pain, the use of naloxone to revert overdoses, and extended access to medication-assisted therapy. And in this respect, the guidelines just come at a time when this is needed and address the last 2 points, use of naloxone and use of medication-assisted therapy. The scientific evidence has shown, it's factual, we don't need to do any more work in that respect. The use of medications, whether it's methadone, buprenorphine, or naltrexone, shows significant therapeutic benefit It improves the ability of recovery and abstinence. It protects individuals against overdoses. It protects individuals against becoming infected with HIV, HCV, and other infectious diseases. And finally, it has been shown to decrease criminal behavior and reincarceration. And yet, despite the evidence, these medication-assisted treatments are not being used. There are multiple factors that account for why there has been a reticence to use this medication-assisted treatment. One of them, very fundamental, is the lack of proper education on the screening and management of substance use disorder in healthcare providers. As a result of that, physicians and other practitioners do not feel comfortable in screening or in providing medications to those that need it. There's another component that is very important that contributes to the rejection of their use, which is the misperception that you are substituting one drug for another. And this actually reflects a lack of understanding about the effects of these medications in stabilizing the changes produced by opioid abuse, as we see in people addicted to heroin or prescription medications. So one of the big challenges that we have, in this case, we have good medications for the treatment of opioid use disorders. So our challenge is in implementing them. And in implementation, it is extremely useful to have comprehensive guidelines as the one that ASAM has now released. And it is because of that, I am very honored to be here. And again, I want to congratulate ASAM for taking this effort forward.
Thank you, Dr. Volkow. That was wonderful. I'm now going to introduce Dr. Frieden, Director of CDC, who is joining us by telephone. Dr. Frieden, are you ready to join us? Okay.
I am, and thank you very much for the introduction, for bringing us together. Can you hear me all right?
Yes.
Okay. Well, at CDC, we've been, as part of the HHS-wide response, both bringing attention to the problem that we face in this country and advancing solutions. Prescription drug abuse and heroin continue to be a public health emergency in the U.S. In the past decade alone, more than 145,000 Americans died from prescription drug overdose. And prescription drug abuse is driving much of the current increase in heroin that we're seeing in recent years. Recently, we saw a large, tragic outbreak of both HIV and hepatitis C in a small rural town in Indiana. This shows that opiate addiction is not only a risk for overdose and death, not only a tragedy in terms of individual lives, but also a way that HIV and hepatitis C can spread rapidly and cause many problems, as we're seeing around the country, ranging from neonatal abstinence syndrome to infectious disease outbreaks to overdoses, deaths, and a host of other horrific social problems. A key driver of the overdose epidemic is underlying substance use disorder, and a key solution is expanding access to addiction treatment services. It's clear that in terms of medical practice, we are overprescribing long-acting opiate medications for chronic non-cancer, non-end-of-life pain, and underprescribing medically assisted therapies of opiate addiction. MATs have been shown to be safe and cost-effective, as Dr. Volkow just reviewed. They increase retention and treatment, they improve social functioning, they reduce the risk of infectious diseases, they make it easier to care for other health problems that patients have. And in addition, naloxone is a life-saving intervention to reverse acute opiate overdose and has a clear role preventing overdose deaths. We need to both improve prescribing for pain, and that's something that we're doing more broadly, and improve treatment of opiate addiction. This means increasing access, quality, accountability. This is critically important, as are measures such as reducing the availability of illicit drugs, promoting social awareness, addressing some of the social challenges and economic challenges in communities and families where drug use and addiction is common, and having rigorous real-time monitoring with appropriate action to address this problem and make continuous progress. At the CDC, as part of the HHS response, we're working to empower state governments to implement comprehensive strategies, including MAT, to prevent prescription drug overdose. And we've recently released funds on a Prevention for States initiative to 16 states in this fiscal year, and we're optimistic that in the coming fiscal year, Congress will respond to the proposal of the administration by increasing that funding so that every state can be covered. It's important that we improve the way opioids are prescribed through clinical practice guidelines that are simple and have clear checklists, ensuring that patients have access to safer, more effective chronic pain treatment while reducing the number of people who misuse, abuse, or overdose from powerful drugs, and treat those more effectively who are addicted. And we are in the process of finalizing draft guidelines which are complementary to these. These address the treatment of addiction. The guidelines that the CDC is coordinating the finalization of are relating to the treatment of chronic non-cancer, non-end-of-life pain. I would just end by saying that opiate addiction and overdose is a true public health emergency. It's a tragic, costly, and preventable crisis, and the new MAT guidelines give physicians a valuable tool to combat the epidemic. Thank you very much.
Dr. Frieden, thank you. I'd now like to introduce Dr. Richard Frank, who's Assistant Secretary of Planning and Evaluation for Health and Human Services, or HHS. Dr. Frank?
Thank you very much for having me, and I want to repeat the congratulations to ASAM for the good work that they've done. As Dr. Volkov mentioned, the Secretary's opioid plan has three components. One is to alter prescribing patterns for pain medications, and Dr. Frieden mentioned that, and there's a multi-pronged approach to that, ranging from physician education to guideline development to work on PDMPs. The second element, which is getting naloxone into the hands of more people in the community who are in a position to administer it and prevent mortality from overdose. The third element, which is what I'm going to focus on, is expanding the use of medication-assisted treatment. Having clear evidence-based analysis is very important in general. It's really important to this secretary. She is all about evidence-based policy. And so having sort of the best clinical research pulled together and combined with clinical judgment that is practical in nature in a sort of simple, easy, user-friendly way gives us greater confidence in sort of developing our proposal, and sort of provides sort of guideposts for us as we sort of go out to implement the Secretary's plan. The formal approach that sort of lies behind the guidelines and their development using the RAND sort of expert elicitation approach makes the pulling together of that body of clinical evidence with expert judgment all the more persuasive. And it's really there that I think there's an extra contribution here that will, I think, allow these guidelines to go further than many others have in the past. As you know, or as you've heard, we recently had a 50-state convening hosted by HHS, but with our other federal partners as well. And at that meeting, the secretary particularly put emphasis on her desire to really expand the use of medication-assisted treatment. And we're doing that in a variety of ways. One way is to put out grants to federally qualified health centers. And as you know, we announced a funding opportunity announcement a couple of weeks ago for about $100 million, which we believe will really motivate a lot of new work in that area. The second area is the Secretary announced at that meeting her directive for HHS staff to engage in a set of revisions to the buprenorphine prescribing regulations. And then the third is we're continuing to work on clarification around parity legislation and parity regulations to allow greater clarity in how parity applies to medication-assisted treatment. So I think I'll stop there, and thank you very much.
Thank you very much, Dr. Frank. I'd now like to introduce Ms. Kana Inamoto, Acting Director of the Substance Abuse and Mental Health Administration, which is also called SAMHSA.
Thank you and good morning. I am really pleased that SAMHSA was invited to be present today and to offer our support. I want to commend ASAM for releasing the National Practice Guidelines and for helping the nation battle the crisis that we are experiencing with opioid use disorder. It's a critical focus, as Richard and my colleagues here mentioned, of Secretary Burwell, and of course it is centrally important to us at the Substance Abuse and Mental Health Services Administration. At SAMHSA, we favor a balanced approach to treating opioid misuse and one that encourages patients and providers to come together for shared decision-making. We believe that people with opioid use disorder deserve and need access to high-quality, evidence-based treatment for their condition, and it needs to include behavioral, social, medical, and psychiatric interventions, in addition to medications such as methadone, buprenorphine, and oral and extended-release injectable naltrexone. As Richard mentioned, last week Secretary Burwell announced at the 50-state meeting that we will move to issue regulations to address the patient limit imposed by the Drug Addiction Treatment Act. I think together with our colleagues, we've begun the process of developing a notice of proposed rulemaking, and so we're not able to comment on the substance of the rule, but the regulations will follow the traditional rulemaking process, including a period for interested stakeholders such as yourselves to review and submit comments on the proposed regs. The ASAM practice guidelines complement and reinforce our efforts at HHS to treat the growing problem of opioid misuse by giving treatment providers a clear path to follow, providing quality care to their patients. I'd like to also commend ASAM for including information about special populations such as pregnant women, adolescents, criminal justice involved individuals, as well as people with co-occurring psychiatric illness, because we know the complexity of treating people with comorbid conditions is great and necessary. The ASAM guidelines echo SAMHSA's balanced approach by including all the FDA-approved medications available to treat addiction involving opioid misuse and overdose. And yet there's still much to do. As you're well aware, a significant gap remains between treatment and capacity. This is particularly acute in some of the states with the greatest need for opioid addiction treatment. SAMHSA, together with our colleagues at HRSA, have recently issued grants to expand access to medication-assisted treatment. And yet just a few weeks ago, when we released our 2014 National Survey on Drug Use and Health, we see the discouraging data that of the 22.5 million people aged 12 or older who needed help with a substance use disorder, only 2.6 million of those individuals received specialty substance use treatment anytime in the prior year. And so the gap is tremendous at the same time that we are seeing a doubling from 2013 to 2014 in the people who are current users of substances like heroin. The good news is that MAT capacity has increased in the past decade. The capacity expansion is in thanks part to approval of extended-release injectable naltrexone for the prevention of relapse to opioid use disorder after detoxification, as well as the passage of Data 2000. The use of methadone by opioid treatment programs for the treatment of substance use disorder has also increased. So we at SAMHSA are hoping that the ASAM guidelines will further expand treatment capacity by growing the number of people who are receiving a balanced, multi-pronged approach to opioid use treatment, including medication where appropriate. There are still challenges ahead. We need to improve public awareness and support. We need to address the risk of diversion. We need to look at issues of reimbursement and coverage, and with tools like the treatment guidelines, we'll be addressing the use of evidence-based practices by clinicians, and we look forward to working together in partnership. Thank you.
Thank you, Ms. Inamoto. I'd now like to introduce June Civilli, Treatment Branch Chief, Office of the President, from the Office of National Drug Control Policy.
Thank you. Good morning, everyone, and thanks so much for having me here. I'd like to say that this is a really significant event. We're very happy. Congratulations to ASAM for publishing the practice guideline. This national practice guideline incorporates critical evidence-based recommendations for the treatment of opioid use disorders, which we all know is a growing concern in our country. These recommendations provide a solid foundation for the addiction field and other providers to consistently and effectively address the unacceptably high rates of opioid misuse and overdose that we're seeing. These guidelines help increase an understanding of opioid use disorder and effective treatments. Increasing the understanding of opioid use disorders will help reduce the stigma surrounding substance use disorders. Words like substance abuser, addict, and alcoholic place stigma or blame on the individual with a substance use disorder and make it harder for people to access and seek out treatment. The ASAM practice guideline accurately reflects and states that addiction is a disease of the brain, and more specifically, that it identifies that opioid use disorders are a chronic relapsing disease. This is very important because even in the medical profession, substance use disorders are stigmatized. One study has shown that clinicians respond more negatively when patients are described as being substance abusers rather than individuals with a substance use disorder. Increasing access to medication-assisted treatment is a priority for ONDCP, as it is the current standard of care, and therefore essential for the medical community to adopt. We do not have medications to treat all substance use disorders, but we do have clear evidence that existing FDA-approved medications are shown to be effective for opioid use disorder when combined with behavioral treatment. Utilizing methadone, buprenorphine, and naltrexone in treating opioid use disorders has been proven to enhance treatment outcomes, and having a concise guideline for the use and prescription of these medications is an important step in maximizing successful treatment outcomes. With increased efforts to decrease stigma and increase access to care, ONDCP and our federal partners continue to work towards ensuring that individuals can access health services that offer adequate coverage for the screening and treatment for substance use disorders, including medication-assisted treatment. All patients receiving medication-assisted treatment should also have access to the full continuum of healthcare services. Additionally, the guideline recommendation for the appropriate prescribing and use of naloxone for treating opioid overdoses is paramount to reducing overdose deaths and saving lives. This guideline provides a framework to a broad audience of clinicians to increase access to medication, treatment, and support, which will make a difference in the lives of so many Americans and their families. On behalf of Director Botticelli and all of ONDCP, I want to thank ASAM for developing this important document. Thanks for having me.
Thank you, Ms. Civilli. I'd like to introduce Mr. Don Flattery, an impacted family member who is serving on the Virginia Governor's Task Force on Prescription Drug and Heroin Abuse.
Good morning. Thank you, Dr. Goldsmith, and thank you, Penny Mills, for inviting me here today. My name is Don Flattery, and I live in the Mount Vernon area of Fairfax County, Virginia. I'm a recently retired federal manager, a member of the Virginia Governor's Task Force on Prescription Drug and Heroin Abuse, and an active participant in the development of a community action plan on opioid and heroin use in my home county of Fairfax. I am not here in any of those roles today. I'm also unlike many of the members of this audience, I am not here as a clinician or a physician. I'm here today as an impacted parent who's lost his 26-year-old, and only son, Kevin, to an opioid overdose 1 year and 25 days ago. While I'm especially pleased to join you to recognize the importance of the development of ASAM's National Practice Guide, my primary goal in speaking with you today is to bring some additional perspective on why this new tool is so important for all Americans, and especially for those afflicted with opioid use disorder. Most of you, as federal officials, state officials, physicians, and public health clinicians, are intimately familiar with the staggering statistics about the explosion of opioid prescriptions, addiction rates, and overdose deaths. I'm acutely aware of them myself, and I'm not here to repeat them today. It's critically important to me and to my wife that we do our part to ensure that discussions about the epidemic of opioid addiction among us and some of the needed solutions, such as the ASAM detailed 170-page practice guide. As someone who doesn't read DVR instructions, I was pleased to see it was boiled down into something more useful. And it's important that these discussions are personalized because, however difficult, these discussions can be far too clinical. It's easy to become immersed in the details of these clinical discussions, but it's also easy to become detached. As you proceed with these discussions and deliberations about the effects of opioid addiction and the role of this much-needed practice guide, I implore you to recall the personal impacts. We're not just speaking about epidemiological facts and obtuse statistics. We're speaking about my son, your daughter, our neighbors. These are real people with real lives suffering from a disease, and their losses are the face of the epidemic we must and can stop. Allow me to briefly share my son's story. On the Friday of last Labor Day weekend, my family suffered the loss of our Kevin to an opioid overdose. Kevin enjoyed the blessings of a typical suburban Northern Virginia upbringing, attending parochial schools, participating in youth sports. He was a varsity high school hockey player. He was a good student and was a graduate of an all-male Jesuit prep school right here in Washington, D.C., and later a graduate of the University of Virginia, where he was a talented filmmaker and writer and active in student and fraternity life. Kevin came to his addiction as a working adult pursuing his passion for film editing and writing in Hollywood and in New York City. He'd been battling and was being treated for issues related to anxiety attacks, stress, and depression. And starting in 2013, while receiving cognitive behavioral therapy help, began self-medicated with the opioid prescription drug OxyContin. He was being treated for dependence and then addiction. He returned home to Northern Virginia in the fall of 2013 to his family, seeking treatment and our support. He was working hard with our help to conquer this disease. Like many struggling with opioid addiction, he tried a variety of treatment options, including inpatient detoxification, intensive outpatient, a regimen of buprenorphine, STEP program support, and a 28-day abstinence-only residential program. But like many others in pursuit of recovery, he experienced the all too common cycle of seeming progress and relapse. Days before he was to start a course of treatment with extended release naltrexone, he relapsed and did not recover. Since my son's death, I've learned a great deal more about the disease of addiction, this current epidemic, its underlying causes, and painfully for me and my wife, some evidence-based treatment opportunities that offer hope, but now only for others. The most significant lesson learned to me relates to the use of medication-assisted treatment born out of Kevin's experience. Kevin was confronted at some AA and NA meetings, and he attended many different meetings over time. They all have their own culture and their own approach. He was conflicted, we were conflicted, and we as a family didn't know better. While there, he was faced with a STEP program focus that included lectures about discipline, self-control, and appealing to a higher power to cure his disease. Few, if any, other diseases in the U.S. are treated in this way. And ASAM's National Practice Guide is clear about the many months, certainly not days, needed to taper off mat support. In Kevin's residential treatment program, he was required to taper off his buprenorphine in 1 week's time. 64 days after leaving the abstinence-only residential facility and being released to the wild, in my opinion, without his mat support, my son succumbed to an overdose. Another lesson I learned. It is a well-documented fact that those practicing addiction medicine, among those practicing addiction medicine, that the afflicted, detoxed, or removed from their mat support are at their highest risk of a fatal overdose, even with a dose that previously barely affected them. When working with local parents seeking information from me about treatment, I strongly encourage them to avoid abstinence-only facilities. By ignoring today's emerging consensus, abstinence-only adherents are unnecessarily contributing to prolonged recovery and in some cases to opiate overdose deaths. This must change. I'm seeing some of that change occurring. I see it in ONDCP's new federal policy to deny drug-free community grants to those states whose drug courts compel their participants to taper off mat medications. I see it in SAMHSA's expansion of funding for treatment to the states. And I was pleased to see HHS Secretary Burwell's recent announcement to take steps to raise the cap on the number of patients physicians may treat with buprenorphine. And I'm seeing it in the National Practice Guide that we're here to talk about today. This guide will serve as an invaluable tool in providing those afflicted with opioid addiction treatment that works and treatment they deserve. I'd like to end with another brief description of another lesson that I believe is relevant, one from the past, which to me is analogous to where we find ourselves today in the struggle to apply evidence-based approaches, sometimes counter to existing conventional wisdom, to seemingly intractable medical issues. Earlier, I indicated I live in the Mount Vernon area of Fairfax County. In fact, I live on the property that was once part of George Washington's 5-farm estate. On a cold, sleeting, raw day in December 1799, and for those of you who live in the Washington, D.C. area, you know exactly the kind of day that I'm talking about. Our first president was out monitoring work on his farms. He came home cold, wet, and soon achy. During the night, he developed a sore throat, a fever, had trouble swallowing, and as the next day progressed, trouble breathing. 3 physicians were called, including surgeon Dr. James Craik, who later would occupy the position we today recognize as the Surgeon General of the United States. These 3 well-trained physicians deliberated about General Washington's condition, which likely was a severe infection of his larynx or epiglottis, and applied a consensus standard of care that called for bleeding our president. Over the course of 12 hours, these well-trained physicians, in a misguided attempt to reduce swelling in his throat, removed 5 pints of blood, likely contributing to his demise. That was the standard of care applied by some of the best surgeons available to the President of the United States, using current medical knowledge, but adherence to past practice. Today, we find ourselves with new evidence-based approaches that we know are showing progress in treating a disease, the disease of addiction to opioids. It's my hope that with new medical knowledge available to us today, with new tools, with new dedication, we can stop applying, as George Washington's well-intentioned physicians did, outmoded, outdated, and potentially damaging past approaches to treatment of complex medical issues. Thank you, ASAM, for developing this guideline. I won't say congratulations, I will say thank you as an impacted parent. And thank you for inviting me here today.
Thank you, Mr. Flattery. This concludes our formal comments. We're now ready to take questions from the audience. We have a microphone that staff will bring to you. Please state your name and organization before asking your question. And we also have a telephone, and there may be questions on the telephone.
My name is Mark Krause. I'm the Vice President of the American Society of Addiction Medicine. I want to also thank you all for coming and commenting. I've been involved in addiction medicine for about 41 years, and unfortunately have lived and relived a lot of these stories and a lot of these things. We now have, and thank you very much, Ms. Flaherty, for sharing your story. I lost a nephew to heroin. So all I can say is that we have an opportunity that we can't miss. And if we don't put into place the people I'm looking at right now, it's going to be missed. We have the population statistics, we have the medical economic statistics, we have the medical assisted treatment, we have all of these things. So be damned administrative things, let's get it on, let's get it there. And I really hope that today is the beginning of getting that done. Thank you.
Our phone question comes from the line of Alison Knopf with Alcoholism and Drug Abuse Weekly. Please go ahead.
Thank you. So this is for Dr. Volkow or Richard Frank. Two questions. What are you doing to increase opioid treatment programs, which have for more than 50 years provided MAT with methadone, are already following strict regulations like these guidelines? The second question is, what are the plans to codify and enforce these guidelines for physicians prescribing buprenorphine, or will they just go on the shelf of guidelines?
Yeah, thanks very much for the question. And so it's Nora Volkov, and I'm NIDA. Basically, the mission is to develop research and science. So we have several priorities as it relates to the use of medication-assisted therapies. One of them is in implementation and try to expand the areas where medication-assisted therapy can be given to patients. For example, with an increase in prescription opioid, we have seen a significant increase in admissions to emergency rooms. So we funded researchers that have actually shown that administration and initiation of medication-assisted therapy in the emergency room itself leads to significantly better outcomes than when you refer them to treatment. This is an opportunity, for example, to expand on the number of individuals that can be treated with medication-assisted therapy. Similarly, other researchers have shown that involving sexual disease clinics, where you see a significant individuals that are abusing prescription opioids or heroin, can be initiating and sustaining the treatment of medication-assisted therapy with significantly better outcomes than when these are just based on referral. So we are doing research to try to expand the involvement of the healthcare system with different specialties in terms of treating individuals that are abusing prescription opioids. At the same time, we are evaluating the application and practices that can increase their use, for example, in the criminal justice system. Extraordinary important opportunity where research has already shown, and it is actually endorsed in the guidelines, that initiating medication-assisted therapy at least 1 month before release from prison can significantly improve the outcomes as it relates to being in treatment, decreasing overdoses, and preventing against infectious disease, as well as better adherence with medical treatment in those individuals that are afflicted with opioid use disorders and a comorbid condition. In parallel, we're also doing research to develop medication-assisted therapies that will be easier to be compliant with, Specifically, for example, we are very interested on extended release formulations that will make it easier for a patient to be on these medications without having to necessarily going on a daily basis to a methadone clinic. And finally, we're also very much engaged in partnership with the other agencies to develop educational materials that can be implemented in the healthcare system and improve both in terms of the management of pain, but also the management of the substance use disorder.
Let me add a couple of remarks to that. First is we are trying to make use of information such as those contained in the guidelines to allow us to better direct the money that we spend through our grant programs to the places that, A, are best equipped to deliver evidence-based treatment, but also in the circumstances, the environmental circumstances where they will have the biggest impact. Second, to build on Dr. Volkov's point on the essentially the reentry community, we are, through elements of the Affordable Care Act, working on finding ways to better connect people with substance use disorder histories with treatment as they emerge from the criminal justice system to make that smoother and prevent gaps in coverage and treatment.
How are we doing on time?
Thank you.
Thank you for the question. Okay, it's time to wrap up. It's 9:45, and we'll bring our press conference to a close. Everyone here is welcome to join us the kind of catty corner end of the floor at the First Amendment room, where we will begin our stakeholder meeting. Thank you again for joining us here this morning at this press conference.